Good evening, everyone. I'm delighted that you all could be here today. For those of you who don't know me, my name is Anisha Ramal, and I am the co-president of the Global Health Interest Group at the UMKC School of Medicine, and I will also be moderating this event tonight. And we're happy to be co-hosting this event with the Kansas City chapter of Partners in Health, led by the lovely Gayatri Kumar. And our objective for creating this event tonight was to foster an environment of critical thinking and discussion about topics related to global health. We're hoping to spark conversations that allow people to determine their beliefs, their biases, and their values in order to forge connections within themselves and others. We want to challenge each other to understand a variety of perspectives in our very diverse community, and we hope that these perspectives will inspire leadership and encourage us to understand that we too are capable of making change in the world of health and development. And so we're just thrilled that you all can be here. As you may have noticed, you got a white card and a pen on your way into the Kiva. These are for you to ask any questions that you might have during the panel discussion. And we strongly encourage you to ask questions and challenge our distinguished panelists so that we can create an engaging and exciting learning environment. Okay. So without further ado, I would like to introduce our wonderful panelists who made the event possible tonight. We have Nick Lundgren, who works as a media producer for Water.org, an organization committed to changing lives through safe water and sanitation. We have Dr. Arif Ahmed, an associate professor of health administration at the Henry W. Block School of Management. We also have Dr. Patricia Kelly, a professor at the School of Nursing and Health Studies at the University of Missouri, Kansas City. And we have Dr. Paul Chan, Associate Professor of Medicine at the University of Missouri, Kansas City, and a clinical cardiologist with the St. Luke's Hospital System. We're very lucky to have them all here tonight. And so now that we are all here, I'd like to go ahead and get started with our first session. And during the session, I would like to explore the individual experiences of our panelists here. I feel like we have a lot to learn from their experiences. So this is a question that I would like to pose for all of our panelists. And Nick, if you don't mind, I'll start with you.
Absolutely.
What motivated you to incorporate global health in your career? And what specific roles have you taken in global health-related projects?
Sure. So my path obviously is a little different from the rest of the panel, being a non-doctor, non-professor. But I sort of always wanted to, and this sounds cheesy or cliche, what have you, make some kind of difference in the world, right? And so when I was still in school, I joined up with Water.org as an intern to go through all their extant media and see what we could do in terms of purposing it and using it to communicate to donors and prospective donors, what the water crisis looked like around the world. And shockingly enough, I didn't even realize how important the water crisis was, and I didn't realize, honestly, that there was a water crisis, which sounds ludicrous to myself even at this point. So world health was always something that was extremely important to me, and then I learned quickly how important access to safe water and adequate sanitation is towards building that base layer of health around the world. So it's become a giant passion of mine in the ensuing 6 years working within the media and with Water.org.
Excellent, thank you. Dr. Ahmed?
Well, I'll answer your question in two different ways. So my interest actually sort of gradually grew in global health, and interest in global health perhaps came much later. My interest in public health came before that. And I was a young equivalent to a resident, an oral maxillofacial surgery resident, practicing in my native country, Bangladesh. And we were practicing downstream medicine. We were doing fantastic stuff with oral carcinoma. We were cutting and sewing and patching people up. But we could not keep up with the flow of the patients that we were seeing. And there was not a lot of attention paid to some of the root causes of those things, particularly if you're familiar with South Asia. One one of the major socially acceptable behavior is use of tobacco in various forms, including chewing tobacco. So that started my interest in public health, and while at the same time, I was part of an institution which was hosting, if you will, global health mission type activities from an organization called Australian and New Zealand Association of Oral and Maxillofacial Surgeons, ANZOM. So ANZOMs would send a group of surgeons, nurses, a whole setup every 6 weeks. We'd get a group, they come, they will perform fantastic surgeries. I was excited to see the Z-plasty for the first time, if you're familiar with Z-plasty. Fantastic pectoral flaps being pulled over, all those kinds of things. But then I was the poor resident after the team leaves to deal with post-surgical care. They're suturing up, they're fixing clefts and palates, cleft lips and palates. We didn't have any speech therapy in that country at that time. They were doing complex maxillectomies and mandibulectomies. We didn't have facilities for proper prosthesis. So that sort of grew my interest beyond my interest in public health. So fast forward, not to take up too much time, right now my role is largely here. I actually teach a course called Global Health and Social Issues. We go to South Africa every summer, and as a matter of fact, there are, I don't see anything here, 3 medical students in this year's trip. Last year we also had medical and 1 pharmacy student who has graciously joined us. So my hope and the idea behind this course is to create an avenue for awareness among all kinds of individuals with an interest in global health.
Excellent, thank you. Dr. Kelly?
My motivation originally was sparked by a human rights approach and really believing that all human beings have a right to certain basic services and care. And I think it was also sparked, I know it was also sparked by being a nurse and feeling very strongly that nurses in this country have fought a long battle to have some sort of equal standing with physicians, but around the world, especially in many developing countries, nurses are so worn down that it's very distressing. And to be for these nurses to see a nurse and to work with a nurse from a developed country has been a very exciting process for me, because they really, I really don't like the word empowerment, but you can see that they can have another vision of nursing and the importance of their work, and that it's not just drudge work. So those were sort of original motivations. I also am a jail researcher now, and that was the combination of being a jail researcher and having a human rights interest was a big part of my motivation to go to Gaza this past January, because Gaza has been described as the world's largest open-air jail. And I have a couple of pictures of that, but indeed it is. And so people's human rights there are very, are minimalized or violated terribly. And to just bear witness to that and to work with nurses and midwives in any capacity at all as an outsider was, and to bear witness to what they were experiencing, I think was important. Just say that.
Thank you. And Dr. Chen?
So before I start, how many of you are pre-nursing? Just to get a sense of the audience. Pre-med or medicine? Pharmacy? Dental? Social work? Other?
Bachelor of Health Sciences
Okay,
program.
so half of you are familiar. So I was born in Hong Kong, but having as a kid when we emigrated to the U.S., learned a little bit about the stories of my parents fleeing during the Second World War when the Japanese had invaded China, and learning about their own struggles with the impact of war on their lives and health. But that was sort of germinating sort of in the background. But really starting in college, I became more politically active and interested in community service. And I was living in 2 homeless shelters in college, and my roommate was a pimp, and we did a lot of activism on homeless work at that time. And I wound up taking 2 years off to do volunteer work. One as a volunteer teacher in Appalachian, Kentucky, with mostly high school dropouts, and another as a lobbyist in Washington, D.C. with a group called Bread for the World. After the first year, after my junior year, after taking the time off, I was invited to do some, or I was challenged to do some work in Nicaragua during the civil conflict with the Contras. And my interest at that time was really to understand the impact of the war on the psychological and the physical health of children. So I wound up spending the summer working with kids in art therapy by myself. I sort of went there on my own, but was keeping UNICEF abreast about the work. And subsequently, after my second year off with Bread for the World, I started going to Guatemala during their civil conflict, and oftentimes visiting communities that had just been bombed within a 3 or 6 month period, and really developed a deep love and understanding and interest in global health, both in terms of how do you actually change or impact communities, not necessarily as an outsider, but to see the evolution of that change, and what is the impact of war that can shatter all that work in overnight. So I subsequently went to med school. I was at Hopkins, and during that time, I wound up organizing health and human rights delegations for medical students around the country. And so we spent time, again, in El Salvador during the civil conflict, and also Guatemala and Haiti. And as I was finishing med school, Paul Farmer from Partners in Health reached out to me and asked if I would come up to the Brigham and do my residency there. And so I said, okay. And I was already applying there for a joint pediatric medicine residency. And so I spent 4 years at the Brigham and Boston Children's, and actually was down in Peru, in Lima, as they were laying the groundwork for the multi-drug resistant TB work, and spent the summer working with Paul and Jim Cameron and Sonia Shen and other folks down there. That was, of course, a great experience. We spent a lot of time with Paul and had many night conversations about everything, ranging from WWF wrestling. His brother is a WWF wrestler. He's part of the tag team duel, which is bizarre. And subsequently, I chose not to continue with Partners in Health for different reasons, but have been involved with doing a variety of different work, mostly with comprehensive health and development work. I oversaw the board of directors of a nonprofit in Guatemala for a few years, and currently serve on the board of Church World Service, which represents about 34 Protestant denominations. I'm not Protestant, but Protestant denominations, doing really good work with sustainable health and development, refugee relief, and resettlement work. And they're involved in about 23 countries throughout the world. I struggle with my time in the U.S. because I feel like I really would rather be outside the U.S. And so I try as much as possible to do education. And so I've been working with one of the private high schools to bring kids down to learn about, not necessarily to do service, but to learn about, what are the social determinants of health? How do you actually think critically about problems that can be applied also in the U.S., in urban Kansas City as well. And every year, we've been, for the last 6 years, we've been doing a walk in the Grand Canyon to raise funds for sustainable health and development. We go, have you been to the Grand Canyon before? It's kind of a fun effort, but we go from one side of the Grand Canyon down to the bottom to the other side and back within 24 hours. And so, Patricia knows. It's about 50 miles. So it's a grand effort. And over the years, last year we had food CEOs join us in the walk. It was fabulous, linking the concept of hunger with people who actually deliver and distribute some of that food.
Thank you, Dr. Chan. I think that we can all agree that our panelists' experiences and work in the realm of global health is something that we as students can certainly aspire to. So Thank you very much. One thing I'd like to let the audience know before I pose my second question is that if you have questions ready, feel free to just hold them up, and Gayatri and Kelsey will come by and collect them, and we can sort of start that process there. The next question that I have for our panelists are, what are some misconceptions in global health work that you encountered, and what actions would you take to correct them? Nick, again, going to start with you.
Yeah, so I think, coming into the position I came into, especially as someone who had not previously worked in global health, I was really, really fortunate to be joined on my first trip to any of our field work. I went to Ethiopia as a volunteer to help film. They just needed someone to film. And I was really lucky to be placed on that trip with an experienced member of our programs team named Laura Ralston, and she really sort of helped shape my worldview in a really amazing way. I think as Western people, as in general, and as Americans in specific, there's this idea of going on like a mission trip or going and changing the world by getting your hands dirty. And I was fortunate enough to learn through my work with Water.org, both in the States and then on that first trip, about how important it is to have people living in communities around the world do their own work and make their own changes, and by doing so really impact their own lives in a much more meaningful way than someone who might pop in for a week, as I do too. But I'm there to learn and to take stories, and I really hope that by doing so I'm able to sort of spread the gospel of work being done by communities living in the places where the problems exist. So that was the biggest thing that I learned pretty much immediately the moment I set foot outside of Mekelle, Ethiopia.
Excellent. And Dr. Ahmed, how do you react to this perspective? Is this something that you can...
Well, both from broader academic perspective, because in my role I interact with literature in global health probably much more than others. So the whole global health literature is actually waking up to this idea that historically global health efforts, and global health is also somewhat newer term. International health, international medicine is not a term that is from way past. I mean, until very recently those terms were used. So the whole notion that we have the solution and we can go and fix things, I think the whole global health community and the literature bears sort of testament to that is waking up to this idea that that is not, and we'll probably talk about sustainability, which has become another buzzword, which is not a sustainable way of approaching issues, and changing the mindset from that to a global mindset is the key to making real impact or making sustainable impact.
And I think you'll hear certain phrases or terms through the language of all of us. So one of the, does everyone know what downstream medicine is? And what would be, so tell them what downstream medicine is.
Okay, so the easiest way to describe it is actually to use a stream as a metaphor. So you are standing by a body of water. That is flowing body of water, and Katie is laughing, but we use that example in our classes. So you see a baby floating by, and you jump and you save the baby, perform CPR and everything, and the baby is fine.
And more babies, and more babies.
Another baby, another baby. So doing that and saving babies at that point essentially is downstream medicine. If you go upstream, maybe you find out that there is a daycare facility or something next to the water body and it doesn't have a fence. So putting a fence around that facility actually solves the problem rather than trying to have 50 lifeguards ready at that point to jump in to save the baby. So that's the metaphor for upstream versus downstream medicine.
And so the most common misconception that I've seen is what is appropriate care and what is appropriate medical care. And because something is appropriate care on the 5th floor at Truman does not necessarily mean that it's appropriate in every setting. And you also heard this phrase, the social determinants of health. So as physicians and as nurses, we are trained here to work with our individual patient, but we're not so well trained to look at the context in which our patients live. And social determinants of health have an incredible importance in this country and around the world, and especially around the world. And many times in global health situations, people go to do their one-on-one medicine and don't look or are completely unaware of the context in which people live. So in Haiti, people were complaining about stomach aches, and they were being given antacids or Tagamet, but nobody thought to ask, what did you eat last? Food is a social determinant of health, and accessibility to food is a social determinant of health. And our desire as medical people to medicalize these issues is perhaps not, is a downstream, first of all, a downstream way to look at them. And perhaps not the most effective way. Maybe we should be looking at assuring health. I mean, another example is, what do you think is the best way to reduce the birth rate in a country? Educate women. So I had a class in public health school with international health people, and I was a nurse practitioner. I was a big family planning person, so I said you have to have family planning clinics. That's what's going to reduce the population. What reduces fertility and population growth is a facet of education. It's education of women. And if you educate women, it is truly amazing what happens. But as medical people, we're locked into providing family planning, which I am not going to trash in any way, shape, or form. But we have to contextualize it.
I'll actually sort of give a slightly different answer to the same question that you asked about fertility rate. And again, if you know anything about Bangladesh, one of the things that you hear fairly quickly is that one of the most densely populated countries in the world. Okay, so fertility and population control has been a major issue from day one. I mean, the country got independence in 1971. So the thing that changed, the issue of population growth control in Bangladesh is women's empowerment, not education per se. And one of the key things in that was this concept called microcredit. And if you've heard about Dr. Mohammad Yunus and Grameen Bank, he started this movement of giving small loans to women for doing things like buying a cell phone, and that becomes the phone of the village. So they do business with that. And when the financial power shifts from the man to the woman, fertility rate actually drops. So who knew that microcredit would be the best solution for controlling population?
When we at water.org, we follow Mohammad Yunus's model and offer a system that we call water credit, which is really just a sexy way to marketize the idea that we're just offering microfinance loans through the existing microfinance infrastructure to allow people to access water, be that through drilling a tube well or through connecting to pre-existing municipal lines, as is often the case, especially in urban slums in Dhaka or elsewhere in India. So we found not only that the access to capital and the access to water can help increase a woman's standing, and these are women who often, were in arranged marriages and may have been married since they were 14 or 15, who may not have had so many options, but by putting them in that seat of fiscal power, it does seem to change a lot of things. And obviously, access to water and/or sanitation is going to change your access to time for work, your access to time for care for your family, your access to make other decisions, not least of which are decisions for your own health and the health of your community. So I think that you're totally right. That access to microcredit in general, and or in specific and capital in general, can be a huge determinant towards communities moving forward together.
Go into the misconception issue, the issue with admission clinics and medical missions, for people who do a lot of medical missions, I think there is a sense that there's a lot accomplished in those clinics. And if it's a surgery medical clinic, oftentimes it can be a very meaningful impact on an individual's life. A child with cleft lip and palate, someone who needs a tubal ligation, those types of impacts can be more meaningful than, let's say, dishing out aspirin and ibuprofen. And for a lot of us in the room who are going to be medical professionals or dental professionals, nursing professionals, and who have a yearning to make a difference, because you're here. That's part of the reason why you're here. The instinctive thing is to do something, hands-on. And I think people feel good when they do these clinics. They feel like they've accomplished a lot. They have followed the faith, or they follow the humanitarian principles. But oftentimes the impact actually generated at the community level is not very much, especially if it's not a surgery medical mission, but even if it's a surgery medical mission. The amount of money that is spent just to bring the teams down, if it was instead delivered as microcredit or water, would be the impact of lives saved or lives impacted would be manyfold. As I've grown in my, not that old, but in my years of really dissing medical clinics, I've realized that there is a purpose of them. All of us have to get involved at some format, in some way. And oftentimes the entree is the experiential contact with people on the ground, in the village. And whether that's going with a water organization, a microcredit organization, it's a little bit more challenging because you don't necessarily bring something to the table necessarily unless you have a lot of money for both parts. And for medical students, they can do something that they'll be doing in their career. So oftentimes that seals the passion for a lot of folks, having that human contact. And so from some of the NGO perspective, I think there's also a misconception that they serve no purpose. They do serve some purpose, but they ultimately serve the purpose of making the individuals who go down transformed. I used to think that really the only model that would work best, talking about misconceptions, for me at least, would be more sustainable development organizations that comprehensively changes or is involved with the community in a collaborative way. That they do water, that they do microcredit, that they do health education training of late health promoters and midwives. When I spent time with Paul in Peru, and we would walk literally from, so we were doing a multi-drug resistant TB program, but what we were doing was we were walking from home to home. We were visiting every patient to do directed and observed therapy. You've got to imagine this is internationally renowned person walking home to directly observe multi-drug resistant TB patients. And Paul and I would have arguments and as to which model served that better, the PIH model or the sustainable development model. And Paul would argue that the sustainable development organizations only work so long as there's cash flow. And unfortunately, there isn't someone who really is present in the community to really bring forth the changes that are needed, whether it's indigenous to the country or outside the country. And so his model is unique in the sense that it's what they call a solidarity model, that they have people from the outside on the ground all the time. It's not in and out. It's not a medical mission 4 times a year. They are part of the community. They are invested in the community. They're accepted as in the community. But they're not the kings or the queens in decision making as to what needs to be done. They work in close consultation with people, whether they're physicians, nurses, or non-medical people, to determine what those needs are. And it's a very unique model, and it's very labor. It requires a whole platoon of dedicated individuals. When Paul left Haiti to do Peru, people are there nonstop, 24/7 from the U.S. In Rwanda, it's the same way. In Eastern Europe and Russia, it was the same way. And it's a unique model that may be part of his, if you will, cult of personality. He can drive the vision of, I mean, when I was at PIH in Boston, medical students were sleeping there. They would literally go from their residency shifts or the intern shifts, and they would come to PIH and work at Partners in Health until 2 a.m. They wake up at 6 a.m. and go back to the hospital and do rounds. These people lived and breathed everything about Paul and PIH. And one of the things Paul has done to make this possible is to create a joint residency at the Brigham in social medicine and internal medicine, so that people actually physically are there 1 year at a time in Rwanda. These are house staff, so that they have the human capital distributed throughout the world. The other last misconception Paul really debunked and really has transformed medical care at a direct level, which is different from what we're talking about in terms of microfiltering and water. Oftentimes, Paul would argue that the cost-effectiveness arguments are unrealistic, and really it's really from the first world perspective. What I mean, 2 examples. In the 1990s, when the AIDS epidemic was rampaging through the U.S., and certainly in Haiti, where they started, Paul wanted to do triple cocktail therapy in Haiti. People, the WHO in particular, said that's impossible. There is no way that you can do this for all the HIV-infected patients in Haiti and be cost-effective. Well, certainly the drugs were very expensive. They were on the patent. But Paul and Jim Kim said, we'll figure it out. And what they wound up doing is both lobbying and shaming the pharmaceutical industry. And now it's the standard of care throughout the world. They were the two lone wolves in the wilderness crying out that this is not acceptable, that we would treat third world and second world, whatever world, however you want to describe people who are in resource-poor countries, differently, just because the resources, quote-unquote, not present. The same thing with multi-drug resistant TB. When they started in Peru, the WHO said, how much is it costing you? And it was costing us $10,000 a patient. We were buying US drugs. We were smuggling them out from the Brigham. And they said, well, we'll figure it out. And Jim, in particular, Jim Kim, again, lobbied this time more than shamed, and they brought the price down 98% to the point where now it was pseudo-affordable by the Ministry of Health in Peru. And now it's the standard of care again, to not leave people untreated, because the thinking was that if you left these people untreated, that it'd be okay. But what wound up happening was it was self-selecting out, because you were treating sensitive cases of TB, and over time, you were seeing greater proportions of people with TB with MDR-TB. So just to sort of answering your question, really the different snippets, that there are different misconceptions about global health. For the people who are starting out, that sometimes the best way to be involved, the most impactful way, is direct service. I'm not sure that that's the case, but it's an important link, oftentimes, to other things that you may want to do and to learn about what's on the ground. My misconceptions, having done some of this work, is that maybe it served no purpose, but I've come around a little bit to thinking that it has some impact, but it would be better with an organization that's there all the time. And the third is that when people say it's not doable, it's not cost effective, it's not always true.
I would say really quickly, I think that there's some importance to, I'm sure you would agree with this as well, to cost efficacy wherever it's possible. where you can make a difference at a tiny fraction of a price that affects, a huge number of people, I think we should always strive towards that, but then completely agree that hopefully that frees up the philanthropic capital to then help cases where it seems insurmountable and like the cost is unusually prohibitive.
But it is an interesting case to think about the cult of personality, Paul, and it's something that can be discussed, but we can't resolve it in any way. And he's managed to certainly attract very powerful people around him, but sometimes it does seem really amazing what he has done and how overwhelming some of those challenges were, and why couldn't anyone else do that? He's just been a very, very unique personality, to say that.
It's an interesting guy. I think Paul is unique, I think. But I go back, I'm a big subscriber in writings by Dorothy Day, who started the Catholic Worker Movement. And she would say, don't call me a saint. If you call me a saint, you basically dismiss my work because nobody else can do it. Mm-hmm. And what Paul is calling on people to do is bring the best of yourself to the table and see what we can get done.
Okay. Well,
the same can be said about individuals like Gary White.
No, absolutely.
So we found it a lot of that work.
Well, I definitely think that we've had a strong start. I've gotten some illuminating points from each of your perspectives and experiences. In the interest of time, I'd like to sort of shift this a little bit to our second session, which will kind of continue in the realm of partnerships. So it's kind of a buzzword in the world of global health, and a very familiar statement that no one organization, actor, or sector can alone tackle global health challenges, and that there are numerous champions in the realm of global health, both the private, the public, and the nonprofit realm. And so I think the question really becomes, how do we translate these partnerships into strategic, measurable, collaborative efforts that truly drive change? And this is the kind of question that I'd like to put to our panelists, who have a lot of answers. Dr. Kelly, I'd like to start with you. How would you define a true partnership in the realm of global health? And when are these partnerships most useful in addressing global health challenges?
Well, I think that the partnership certainly has to be with people on the ground, and there has to be a U.S. organization that has some structure, but I think that actually one of Paul Farmer's really important messages is that you have to work to build the government. You have to work with the government that is there, however problematic that government might be. And that is not going to happen in 6 months or a year, so that a long-term vision, a long-term sense is very important to really look at short-term goals and long-term goals, and to evaluate those goals so that we want this partnership with a strong local organization, preferably the government, and you want to really be evaluating not just in terms of what, I think that seems okay, but really looking at this in terms of having some measurable goals. And it doesn't mean you're always going to meet them, but you really want to have something that you're striving for. And it's actually very challenging, as you all know, because the field is always shifting, and you thought you could do this, and then this seemed better, and so you move over here. But keeping some of those goals in mind, and not just responding to day-to-day fires with your in those partnerships, I think is critical.
And were there specific entities that you partnered with in your personal global health efforts?
I actually had a very nice time training midwives in Haiti. There was a very it was a good organization. They were training women who were not trained to do safe births, and they put out 20 people a year, and it's a great organization, except that they only focused on safe births, and they didn't focus on spacing. And I had a whole discussion back and forth with them about spacing. So why spacing important? Does anybody here know that?
Spacing between babies.
Yeah.
It works allow the body to heal. Like the body to heal.
Right, so what are the two things that would most contribute to maternal mortality?
Hemorrhaging.
Well, overall, what is going to keep maternal mortality down in any country?
Less pregnancies.
So the answer is safe births, so that we don't have women dying at birth, and fewer pregnancies in the form it would be better to say spacing rather than fewer pregnancies, because you can have some spacing, and spacing will allow some time. And this group was very concerned about offending their Catholic donors, and frankly, I had a fit. And after they said that they were doing spacing, that they were giving out birth control, and they weren't. And so we had a discussion back and forth. But it was a very good group in terms of training. They were doing training, and they wanted people from the states to come to help train and help them in their training modules, and to help them be doing hands-on learning. So that's a very nice group. I think also we've seen now some real sustainability from partners in Heart to Heart. Heart to Heart went to Haiti to do relief post-earthquake, and they're still there. So they're still there over 10 years later, and they have all Haitian staff. They're training community health workers, and I think they've really been influenced by the Partners in Health model, but they have their own vision too, and certainly some weaknesses, but it's jumping to your next topic. But a partnership with them, I think, offers a very nice opportunity for people.
So, Nick, I know that you've worked with some entities. If you want to lend your experience.
No, absolutely. I mean, I think partnership, as everyone is well aware, is key to successful development work, successful global health work, and really just, bluntly, successful business work here in the States too, right? You can't get anything done without partnering with relevant people. And like you said, the government is tremendously important. We worked with a number of different agencies and lobbyists within India to try and get water and sanitation lending changed to priority sector lending, which would allow capital to be dispersed at different rates, which is a very specific case. But we work around the world. Our work is focused on partners, and that's partner organizations on the ground from one of our very first partners, REST, Relief Society of Tigray in Ethiopia, who we helped build up with our fundraising efforts, all the way to our latest partners, the microfinance industry throughout the world, be it the Grameen Kutas of the world, or even some more traditional charity organizations, like an organization called ODP, Organization for the Development of the People, which is based in Mysore, India, and they were basically a Catholic charity, and now they have opened up a separate, what's called Section 8, but has nothing to do with housing in the U.S., Section 8 entity to allow them to become a lending entity, giving very, very, very low APR, it's not called APR, loans out to people. So it's been super important for us to work with people all over the world. And then, of course, we have close partnerships with our local staff who live and work in these countries, in Bangladesh, in Ethiopia, in Kenya, in India, in Peru. And then our funding partners here, too, who are super important, be they obviously this is sort of where I come into things as a marketer, but every one of our donors is a partner in helping fund our work with our other partners. And then we have large organizational grants from institutions like the PepsiCo Foundation or IKEA Foundation. Those are important partnerships as well, because without their funding, we wouldn't be able to do some of the riskier things that we do.
So with these people that you worked with, what would you define as a successful partnership? What works?
Sure. So, like I said at the very beginning, I think one of the most important things, and granted, I'm not on the programmatic side of our work, so I don't connect directly with the partners in the same way that someone on our broad and really capable programmatic team would. But a successful partnership is one where you both listen to one another. And I know that sounds maybe trite or a little too simple, but it's true. I mean, the ability to sit down and have a two-way conversation is the key. The ability to share ideas. One of the terms that always stuck with me from when I first joined water.org was technology agnostic, which was a way that we described sort of our traditional grant-based work, subsidy-based work, where we would come in and drill a well through one of our local partners, something to that effect. And what technology agnostic meant was that we weren't going to bring in the newest technology. We weren't going to come in and bring some crazy new mechanism or some giant statue that wicks water from the air. We were going to listen and find out what solutions people had found successful already in those geographies, in order to create the most sustainable solutions. And then additionally, partners that were willing to listen to us and hear from our experiences around the world and from our experts in finding water tables and things of that nature. So conversation, listening, mutual respect are the most important aspects of a partnership.
Excellent. Dr. Ahmed, what are your thoughts?
So I'll start with my current partnership. So my current partnership is actually in the context of the course that I mentioned. So our partner is the University of Western Cape School of Public Health. And in the same realm, in terms of doing projects, be it water, be it other kinds of clinical partnership, we use South Africa as a case study, right? So my co-instructors sitting right there. So we teach, right? So we teach a lot of constructs, theories, and so forth, and then use South Africa as a case study to maybe validate or challenge some of those constructs. But the most important part for us to make this course what it is today, and I mean, whether it's successful or not, I'm not going to make that claim one way or another, but is to allow our partners there to essentially shape the experience that our students get in South Africa. So from the get-go, it has been informed and pretty much designed by them. What is important for us to know, and every time I go there, I learn. So that actually sits under the umbrella of a larger partnership, which is going to turn 30 years old this year, which is called the University of Missouri South Africa Education Program. And we started this course actually with a grant from that program. And I'll come to a question, one-word question, why, later on when we talk about sustainability. So that partnership was started during the apartheid era to essentially sort of go against the grain of divesting from South Africa. And the University of Missouri system decided that we should actually empower the people. So the University of Western Cape used to be, in the apartheid era lingo, a colored university. So the oppressed part of the society, University of Missouri decided to partner with them, starting with faculty exchange, and now it has student exchange. So both why, what you are trying to do, and also reliance on your partners. Those are the two key things that is at the core.
Okay, excellent. And Dr. Shan, do you have any words on this subject?
The word partnerships is complex. In the non-governmental organization world, the NGO world, that do a lot of the projects that we've been talking about, one of the sad things is that it feels oftentimes for me like academics. In academia, I'm a researcher mostly, and when I was interviewing around for jobs, most of the places that were traditional large academic universities, people were not collaborating. They were actually fighting for the same pool of money, grants. Right? The reality on the ground is that oftentimes it's not that pretty in the developing world, the resource-poor countries. Even if the organizations are well-intentioned, and I'm sure all of us can speak to this, but it's not uncommon for a region in whatever country to have multiple organizations doing the same thing, competing for the same monies, not working together, and really against each other, competing against each other. And in some ways, it's a disservice for the communities because oftentimes the sum is much greater than the individual parts. And it is essential that if you become involved in this work, that collaborations, organizational collaborations and partnerships is really the way to go to really, if we really care about the communities that we are immersed in, learning how to jointly collaborate and apply for monies together that can be shared will ultimately get a lot more done and impact more people. On the personal level and on the individual level, when we do this work, the partnerships have to be with the people that the programs we develop purport to serve. The people who are the so-called poor and resource-poor countries oftentimes have great ideas and present interesting innovations to some of the problems that they encounter, whether it's water or economic development. And so there isn't a one-size-fit-all program for every country for whatever thing you're really looking at. There are options, and often one of the things that Paul Farmer and others have really emphasized is the fact that we need to listen as much as to suggest, opportunities for improvement, because it's really a partnership. And for Partners in Health, it really is a partnership with the people that they walk in solidarity on a day-to-day level. And finally, the partnerships, as Patricia and Nick have mentioned, and Arif, is that you need to go beyond traditional health organizations. Governments are going to need to be allies if you want to be successful on a more than a village level. If you really want to make the impact in MDR-TB or HIV, you're going to need to work within the infrastructures of the ministries of health, as well as the pharmaceutical companies, if you're involved in trying to work with negotiation of rates. It was not uncommon for Paul's a pretty convincing guy, and so is Jim Kim, to have some pharmaceutical rep come down and actually see the work that Partners in Health was doing before they became convinced that this was a pressing global issue. Those types of partnerships, instead of shaming, changing, can really, really transform the type of impact the organization and an individual can provide.
I'd like to introduce a question from the audience. You've all talked a lot about collaboration and integrated work, but one of the audience members asked, how does an organization help enact policy-level change in countries where the best practices or the standards of care are not practiced? Dr. Kelly, would you like to tackle this question? And I can repeat it if that would.
How does an organization make change?
In countries where the standard of care or the best practice are not practiced, how can they influence the policy making?
So I'm going to tell you about one project that I have started as a result of going to Gaza. I asked these midwives if they would be interested, a group of midwives from the Ministry of Health with whom I worked, if they would be interested in doing a project called Photo Voice. And Photo Voice is a research method in which you give people cameras, and now you just give them cell phones, and they take pictures of a specific topic, and they come back and talk about the pictures in a very specific way. So this is not a large-scale effort by any means, but this is an effort that these women were excited about, and I hope we are working on moving ahead on this project to talk about births in Gaza. And one of the very interesting things about it is that it's a country where women are very, very fecund. They're at least, the average woman has 7 children, And so repeat cesarean sections are a real problem. If you have one section, they might do vaginal birth after delivery and give it a trial. But there are women who have section upon section upon section. And this is a health problem in this small population. And so the midwives are going to document their practices in some way, both their positive practices and their negative practices, and hopefully be able to comment on this and use social media. Photo Voice traditionally was devised so that after you got your photographs and your comments underneath them, you then put the photographs, display them in a public place, a library or a government building. But social media has changed all that, and so we're looking for social networking sites where this whole display can happen, such as the International Council on Midwives. So that's just a small individual way, but to start letting people know about what the practices are in a way that is not traditional research, that is not something that you get published in an academic journal, but that you use research skills to document and try to move change forward.
That sounds like a very practical and effective approach. Dr. Ahmed, do you have any thoughts?
Well, I'm actually going to sort of not take an issue, but
We argue a lot.
challenge, not take an issue with you, but challenge the core notion of standard of care. So, what standard of care? Standard of care defined by whom? In what context? We go to South Africa, and traditional medicine is a major component of people's lives and living and healing. And can you think about herbal medicine as part of your standard of care? Is it standard of care here? If you go to China, in major hospitals, if you go into the pharmacy, the same pharmacist, and we have the pharmacy student here, so you can vouch for that, would be filling prescription written by same provider for the same patient, relying on both Western remedies and traditional Chinese remedies. So it is context specific. So if I say that, well, I go to Guatemala and I see that standard of care is not being practiced, I need to understand the context before I even try to change the policy. So I think that's where we need to start, rather than saying, well, what I see doesn't fit my mold and it needs to change. Maybe it doesn't need to change at all. Or maybe you can inform it to improve it, but it does not have to fit what I think is the right way of doing it.
Excuse me, I think that I asked the question and thank you for your comments, but I think my question was quite specific and it was quite lengthy and quite understandable. You showed on that. So in India, the dot medicine for tuberculosis, instead of the recommended method of providing it consecutively each day, what the government has done is they have changed it from each day to alternate days. And from a non-profit organization perspective, how do you make a change in the policy of how the government decides what is going to happen?
That's an interesting dilemma, and I think depends on the capacity, and probably Nick can comment on that more in terms of dealing with sort of the different hierarchy of power structure. Now, if the organization has the capacity to document the effect of that policy on their outcomes, maybe that could be a starting point, or if the gaps can be filled from other sources, that could be another approach. But those are, of course, realities that you face in those kinds of situations, and sometimes you may be able to affect change, sometimes you may not.
And that was the case we encountered in Peru, which was when MDR-TB was blossoming, and the WHO had actually cited the Peruvian DOT program, directly observed therapy program for tuberculosis treatment, as a model for the world. They were not alternating therapy. For multi-drug resistant TB, if the patient was 4-drug resistant, they would just add one extra medicine instead of adding 3 or 4 new completely sensitive treatable medications. And what Partners in Health did was they tirelessly worked and communicated with the Ministry of Health, to talking with their physicians, talking with their administrators, for them to really show that if they pursued this strategy long term, they would actually spend more money in the end, because the spread of the epidemic would affect more people. And so I think I assume the reason for switching to an every other day regimen in certain places around the world is for cost. And so that's what the argument needs to be made, to really convince the policymakers that it actually will cost more money in the end. Because by trying to double the number of people treated, you ultimately will be creating a spread of either sensitive strains or emergence of resistant strains over time. And there is now more data than there was 15 years ago when they started doing the MDR-TB program in Peru. But it needs to have somebody who's passionate, who's present there, who's part of an organization that is got some standing, and they have to be savvy politically. I mean, not what we think of politics, but just conversationally savvy, to be able to convince and to persuade, but to also make the argument in a way that in this case, the Ministry of Health in Peru saw it as their idea in the end, so that it wasn't a shaming of the WHO, who's already cited them as the model for healthcare for TB treatment, not to make the WHO look bad. And so they were able to successfully do it, but it's not an easy line to walk. The flip side to the question is, for policymakers in the US, there are things that we can all do that affect hunger on a day-to-day level, on a policy level. When I was at Bread for the World, what this organization does in DC is it works on several pieces of legislation every year that are critical to domestic and international hunger. Things that you would never think of because they fly under the radar, whether it's WIC, whether it's foreign aid, and what type of foreign aid and what type of conditions are tied to that foreign aid. What I was involved with when I was working there for that year was foreign aid to the Horn of Africa, Somalia, Sudan, and Ethiopia. The foreign aid in the U.S., we were worried, was being given to the countries that were in civil war, and they were using, the countries were using the food, the foreign aid, as a political weapon, only delivering it to the areas that were supporters. And so what we were lobbying was trying to condition that the foreign aid that is given to the U.S. is unconditional in that sense. It should be given to both sides. It did pass, but it was not without persuasive and diligent efforts on many people's parts. And what Bread for the World does is ask citizens to contact congressional people and to basically flood their offices with phone calls when they know that legislation is up. And so it's really building a coalition on the ground. I recently met with a Bread for the World regional person in Kansas City. College students, medical students, nursing students, you guys are right because you guys have so much passion and you can use social media to generate the calls and the letters. This is what you can do on a day-to-day level while you're even in your studies. And it's something that can have multiplied effects, both for people in the poorer areas of Kansas City, but also around the world.
Thank you, Dr. Chen. Nick, if you had anything.
No, I would just say quickly, I think you're totally right. You have to work within the construct of the government as it exists. So, part of the reason we were able to get water and sanitation lending as priority sector was because we were able to use the language of PM Modi's Swachh Bharat to sort of convince them that this was another way to make that happen. So it's definitely, you know, a politician likes to be right. And so if you can tell them you are right and here's why, then they'll do it. That doesn't mean it's necessarily easy when you're talking about something that will likely increase care costs by double, but.
Well, at this point, I would like to move to our last session on global strategies. In this concluding session, we'd like to focus on the overarching principles that guide the future of global health efforts. And the place I would like to start is the Millennium Developmental Goals, now known as the Sustainable Developmental Goals. In September of 2015, the UN Millennial Developmental Goals were reevaluated and expanded to 17 goals, again, renamed the Sustainable Developmental Goals, excuse me. And I'd like to ask our panelists, how would you define sustainability? And is sustainability a valuable criteria to use in defining global health goals and outcomes? Dr. Ahmed, I'll let you start on this question.
Well, when you talk about sustainability, again, I'll answer that question with a question: is sustainability of what? And the question underneath that is why you are doing what you are doing. So I think as we think about global health efforts at a larger scale, the question is now becoming what is the right model of governance of global health efforts? So we talked about partnerships, collaborations, and so forth, and there are, if you just count the major initiatives and intergovernmental bodies and organizations like WHO, the number is about 175 foundations and so forth as you put them together. So lots of things are going on, and there was this question of coordination. So it boils down to bringing together as much as possible the interests of all the different parties involved in this effort to make the greatest impact. So if you think about sustainability in terms of broader goals like MDG and SDG, there is of course one level of sustainability, but then as you bring it down to individual levels or organizational levels, then the question is, are you able to meet your core objective on a longer term basis? Now, eventually that need may shift, that priority may shift, but having a longer time horizon and meeting that objective, I think, is how I look at sustainability, whether it's international development or global health.
Dr. Kelly, first.
I'm sort of interested in this audience here, and what, if you don't mind my asking this question, what, where do you see sustainability? Where do you all fit into this? Are you just thinking about this idea of global health right now? Are some of you planning on going somewhere, working with someone? Are you just observing and thinking?
It's something I'm interested in, but at this point in my education, it's very hard to feel like I can be actively involved in something because I'm just beginning medical school. So I have some time before my role could come to full fruition. I have maybe an image of that, and I would assume many of us have an image of what we would like to do one day. But we may not be in a position to do that right now. So my struggle currently is what is my role today? It's very much education in and of itself is the way of gratification in many ways. But specifically for this, it's, I don't feel like necessarily I'm making a very big impact today, tomorrow, next week, within the next month. But I hopefully one day you'll be able to realize the image or the goal that you have of being able to do something that is sustainable and not just sort of this drop-in medicine that I've seen, or voluntourism, as often students like us are kind of marketed to. So it can be very discouraging on a day-to-day basis to think there are a lot of these problems that I see, and it's hard to kind of pick one. It's kind of hard to pick a place or a specific organization. But further, I would say, it's very difficult to stay engaged continually without an ability to really enact change or to feel like you're contributing much.
Very courageous statement, I will say. Anybody else?
I was very much like him. I'm getting ready to finish school, and frankly, I'm becoming more and more not impressed with the way global improvement is coming along. I went with Arif to South Africa, and we went to one slum in one town, in one country, in one continent, and the amount of just poverty that was going on there was just overwhelming. And even in Bosnia, back where I live, seeing how people are drinking unclean water miles from any hospital anywhere, it's just so hard to imagine us ever overcoming that and actually attaining the goals that we set, I guess, every 10 years or so. Just keep pushing it back. But sustainability is one of the new buzzwords, and I don't know, it just seems so obvious to me. I think we should have started implementing that decades ago. So I'm interested to see where it'll end up, or what new buzzwords we'll find.
Actually, I'm sorry, I'll just steal one quick, so I'm actually stealing it from a lecture Paul Farmer gave in 2014, so I watched the video, and he has a chart there, and essentially talking about the same thing, that if we track the use of word sustainability, eventually it may become unsustainable. Again, sorry.
So, and then I will just say, from a marketer's perspective, I mean, looking at the SDGs, it feels like the Sustainable Development Goals. It almost feels like a retread, right, of the Millennium Development Goals. But from a marketer's perspective, it's not harmful to have a goalpost to point at. So even though it might not be the most ideal thing, it's something we talk about. SDG number 6 should be number 1, guys.
And we have a few slides as well. Yes, it's that one. Is there one in particular?
Well, actually, number 3 is the SDG slide. So
Yeah.
Thank you. That's very helpful.
that's.
I think you raised an interesting, the gentleman that spoke from earlier in medical school, he raised a difficult question, or a question that many of you have, which is, when am I going to get started, if at all? And it's one of those things that there is not a right answer. You know, when you're finished with medical school, there's going to be an internship and a residency, and maybe more beyond that. And after that, you're going to have to pay your loans. And so, what is the real sustainability, if you will, of that interest over time? And then you may have a family, etc. There is no right time, but I think finding a way to get involved is probably critical. Now, that doesn't mean that you have to go overseas to do that. If you find an organization that really captures your vision of where you want to be involved with, or that you would like to support, finding ways to support that organization can oftentimes do more than going anyway overseas. But what I usually counsel people to do is tie it to something more direct locally, when you want to do something hands-on, so that you don't feel totally like you're just sending money to an organization. There are a lot of needs in Kansas City. We oftentimes forget those of us in the global health community that some of the problems exist here. I mean, after I did my residency, before I figured out what I wanted to do with my life, which I'm still trying to figure out, my wife and I moved and lived in the Navajo reservation for 4 years, and we found so-called third world conditions literally in the U.S. 50% of people don't have running water, as many don't have electricity, there's no jobs, and there is both under and overnutrition there. But one of the things, I have a 14-year-old and an 11-year-old, and my 14-year-old is a freshman in high school, and one of the things we made a commitment to each other this year was to get her more involved in direct service. Again, it's the same thing as doing a medical mission clinic, but at the same time, it gets her to see what's out there, to feel what it means to be involved in a whole different socioeconomic class that you wouldn't otherwise be in, because we're all middle class, most of us middle or upper class folks, and I think I've seen sort of her something is spinning in her mind. She's oftentimes, we were involved in doing some meals recently in a Catholic worker house in Kansas City, and as we were driving back, she said, I don't exactly know how she described it, but she said she felt so warm inside it felt like she was going to burst. This is from a 14-year-old who usually doesn't say very much. For me, it's not so much what she's really doing when she's there, but she's connecting with herself and with others, and she's learning about herself and feeling like she's not disconnected and powerless in the process of having to be in a 4-year medical school. So find ways to get connected, find ways to be involved locally so that you don't feel disempowered and powerless. And find a way to be involved if you're interested in the global health cause. There are a lot of organizations that do really good work. And if it's water, if it's microcredit, whatever it is, find ways to support it through bake sales, through walks, that you can really make a difference in that organization as well.
I gotta make a pitch for refugee services in Kansas City too, because they are, while as a country we're incredibly minimal in what we accept, but there are families who are coming in. There's Jewish Vocational Services, there's Catholic Charities, there's Don Bosco, and I'll just tell you a story. I saw these two women in Philadelphia airport who were getting on the plane for Kansas City. They were dressed in full covered up garb, and I asked them where they were going. They were coming from a Somali refugee camp, and they were relocating in Kansas City. And I said, well, I'll talk to you when you get off in case your people don't meet you. But I got to be the first person to say to them, welcome to America. And I'm friends with these two women today, and it's a very moving experience to be involved with these communities and see what they're going through.
Well, can I just add to this a little bit?
Oh,
so, I cannot get away from my academic self, so go back to sort of an academic-ish statement. So if you look at definitions of global health, and again, if you look at the literature, there are tons of definitions, and they don't all agree. Somebody actually looked at multiple definitions of global health and sort of read through them and identified the primary characteristics. And the two characteristics that pop up most frequently, one is equity, and the second characteristic is sort of globalness, global mindset, in the sense that it is not international, it is not bound by boundaries, it is the collectiveness as one humanity. So at least in the global health literature, that's the vision that all the ideas are pushing towards. So if you are not able to travel overseas, you can still adopt that global mindset that everybody else talked about, that being able to understand others' situation and strive towards those core concepts. I mean, being from Bangladesh, it's an advantage that Bangladesh is cited quite frequently as comparison for badness, right? So infant mortality rate in Bangladesh is actually better in the sense lower than some parts of the Bronx. So you don't have to go outside of the United States to be able to see inequality and sort of work towards those. So you may be able to do something outside of the border, maybe 10 years, 15 years down the road in your career, but you can start locally, start impacting locally.
So these are great words of advice for a large number of the audience are students, and we have a lot of things that we want to aspire to. So hearing these words are reassuring and inspiring. Nick, do you have anything to add?
No, I mean, I completely agree. Everything is super connected, and there are issues in every part of the world, including 10 feet that way. So,
Nick, do you want to talk about the microcredit fund for water in terms of the question of sustainability?
yeah, absolutely. I mean, microcredit, just by virtue of the fact that it's not traditional hands-on-the-ground programmatic work, we have found to be an extremely sustainable solution, not just in terms of economic impact, of course, but also building off of one of the core tenets of our previous work, which was that ownership and pride of a project, what we call a project, what a person receiving it would just call a tap or a pump or water or a toilet. But economic investment and ownership in that piece of equipment guarantees sustainability at a level that almost nothing else can, because you take your own personal pride. There are numbers on this, and if I had them, I would tell them to you. I apologize. Yeah, it's pretty amazing to see people taking pride. I had a woman who would not let me leave her new toilet until she had shown me the beautiful tiles that she was so proud of, and it was awesome. I mean, she was just cool and sweet and very vivacious, but it was really, really nice to see how full of pride she was of a toilet, right? And we sometimes take these sorts of things for granted, and that's not to be judgmental. I take things like that for granted every day, but they're pretty amazing and powerful. And then from the economic side, you can make such a huge impact by providing a loan, because of course a loan is repaid. A loan is able to then go to the next recipient and the next with just the same philanthropic capital that began the whole process. So it's a really, really been a phenomenal thing. I remember the 1 million people reached party we had, which was, gosh, that would have been like 4 years ago. And we, as an organization, started in 1989, 1990, depending on your definition. And that was a huge deal, obviously. I mean, we had reached 1 million people. That was earth-shattering, especially, and not least of which for Gary White, who started this as a passion project while he was in school. On one of these much maligned voluntourism trips, he first discovered the water crisis and made it his life effort. So I do think that there's a lot of value in what you're saying in terms of the spark being ignited. But anyway, I remember how huge that 1 million people reached party was, and now we reach over 1 million people every year, thanks to the water credit program, which works again through microfinance. So it's been pretty amazing. Granted, the program has been around since 2007, so we still need to do some efficacy studies around sustainability, long-term, short-term, mid-term, but it's been amazing to go view the work. And I just actually got back from a trip in December where I saw work from 2007 and 2010 that was still functional and changing people's lives every day.
Just to give you a mental image, Gary White approached a handful of donors to raise $8 million last year. And up until then, they were doing very small pilot projects, but most of the water projects You know, if you spend $100 on a family to get water, you have to raise the next $100 for the next family. This $8 million sort of fund, they convince people to give them a total of $8 million, and they would get their money back in 7 years with 1% interest. And you say, who's going to invest in an investment fund that's 1% interest? Well, the whole point of it is not to make money, but they would then use it as microcredit to loan twice a year that $100 or that $1,000 or that $100,000 that the individual gave, and it would be loaned twice. Over 7 years, it would be loaned 14 times. So the idea is that the $8 million gets paid back to the initial persons. They get pretty much a loan. They basically loan the money, and they know that that money has been transformed. If it's $100,000 at 100 person, they were looking for 6 and 7 digit donors. It's $100,000 and it's $100 per family, just to make the math easy. It would affect, if the money was totally spent and not replenished, 1,000 people. But now with 2 cycles over 7 years, you've now affected 14 times more people and you haven't spent a dime.
So it's a slightly separate program, what you're talking about, to our general water credit fund. Our general water credit fund, just so everyone knows, is financed both by institutional partners but also small scale 2 or 1 digit or 3 digit donors like myself. And those loans are financed through the microfinance institutions themselves and through the extant capital system. And while we are able to do that at a much lower rate than the usurious rates that people were paying for water, and at the lowest possible rate, it's still not low enough for our belief, because we would like it to be an interest-free loan, all things considered, because they're repaid at a rate of 99%. We don't need to make a profit. We just want to lend out the money. So what we have done, or Gary rather, came up with this idea of the Water Credit Investment Fund, which would allow high-impact social investment donors to invest money. And we are currently working through governmental structures because, as you may or may not know, it is very hard to bring money into a country from the outside for a lot of good and bad reasons. So we're working through all those governmental structures. Thankfully, I don't have to do that because I have no financial background, but we have a team of really, really smart people working to get that passed through. It's pretty amazing to see.
Excellent. So we are now unfortunately drawing towards the end of our sessions on a bit of a time crunch. But before we conclude, there's one last question I'd like to pose to our panelists. And somehow this sort of started to be answered organically within the discussions, but I would like to ask all of you, if, in one sentence, if you could offer advice to our students who are interested in incorporating global health and public health into their careers, what would that advice be? Nick,
Sure. So in one sentence, I would say, just try new things. That's what I did. I mean, I went to school for film and media studies to do film theory and filmmaking, and I ended up working not necessarily in global health specifically, but global health adjacent at the very least. And just take opportunities where you can find them, and like everyone else has been saying, find local nonprofits and local people who are making a change, and do what you can with your talents right now to assist them. My talent might not be drilling a well, but hopefully through what I do, I can help make that happen for families around the world. That was way more than one sentence, I'm sorry.
Dr. Allen?
I'll give it to you, one short sentence. Think about health in a broader way. If you're able to do that, I think many of these things will fall in place.
Read. Talk to other people about your ideas. I know you're studying biochemistry, I know you're studying a lot of stuff, but try to find one book on these topics and just keep reading. Another book, another book, another book. Eventually, these ideas will come to some kind of germination.
Do you have a suggestion of a book or where we can start?
Have you read all the Paul Farmer books?
Why don't you start with Mountains Beyond Mountains? This is biography. But then you'll delve into the more intellectual stuff. But it's by Tracy Kidder. He's a Pulitzer Prize winner for something else.
Very readable. He's
But it's easy to remember. Mountains
He's a
Beyond
journalist, so you will just read it easily.
would say is to try to always make decisions with what you, not with your mind per se, but with your heart. Usually your heart is right. You know, the amount of years I've taken off doing things before I completed my medical training, I don't regret. You know, I think they've informed what I've done subsequently, and they've informed me as an individual. When I took a year off after junior year in college, my mother did not talk to me for 6 months. You know, they left everything to come here, and they thought I was dropping out from Harvard. So, and then when I left the Brigham and lived on a reservation for 4 years, everybody thought I was nuts because everybody went into oncology, cardiology, and did a fellowship. And I said, I don't really know what I want to do, but I know I want to do this. And it wasn't about paying off loans. It's hard when the loans are up there. But there will be an answer to those other issues. There is loan repayment if you work in a reservation. But there are other answers that will make it doable. But you need to be happy and to be honest with where your passions are. And sometimes it's not the biggest paying job. And oftentimes it isn't. But it's going to be what makes you the most happy. And you'll be surrounding yourselves with people who make you the most happy.
Excellent, thank you. And I would just like to, again, thank our panelists for providing such a nuanced and thoughtful discussion. I think we all definitely learned a lot. And I'd like to thank our audience members for engaging and being willing to learn and collaborating with us for our first panel discussion on global health. And hopefully we'll continue to have more. So again, thank you all for coming. We have some food left back in the cafeteria for you guys, and we will take a few photographs. So thank you very much.